you decided to go out to Chelsea. Had you done something like this before? And what led you to try this pilot study?
Yeah. One thing that we knew in the hospital is that there was a large percentage of people, inpatients, COVID-19 inpatients on the floors and in the ICU that were from that community. And it was many more people from that community than we usually have in the hospital. It became clear that something was going on in Chelsea. The physicians on the ground at the Chelsea clinics knew that there was something going on, and obviously the folks in the hospital knew there was something going on. So we asked the question, can we go to that community and begin to test people who don't have symptoms yet and find out how many people in that community may have been exposed already and maybe didn't even know about it. So I can tell you, we know about 1 to 2% of the Chelsea population has tested positive for COVID-19 by PCR using the nasal pharyngeal swab test. That's a pretty high number, right? 2% is a pretty high number. But we were asking, and I think many people would ask, well, how many people in general have been exposed? Is it 2%? Maybe that's everyone. That's 2% is everyone. Maybe it's 5%. Maybe it's 30%. And so we didn't have information. We didn't have the information. People were speculating. So it's really important for us to get an idea how many people in that community are infected. What are the risks? Can we help mitigate the risks and give useful information to the residents? So that's why we started. We hadn't done this before. We've been developing antibody tests at MGH for over a month and a half, knowing that we would need these tests later on. The PCR tests are the most important ones. Like the PCR test is the gold standard for diagnosis. You absolutely need those. And everyone's been focused on getting those PCR tests at scale, at volume, I should say, for the communities. But antibody tests become important later on when you want to know how many people have been infected. The other thing people are interested with antibodies are, of course, am I immune, right? I think most people are interested in knowing, am I immune? Can I go back to work? Will the state or the country have a rule about if I have an antibody that I'm safe to return to work? So there's a lot of interest in that. But there's important uses of antibody testing just to see where a community is in the infection.
So you go out, you set up a tent, walk us through the process, and then what did you find? Yeah.
So we really just wanted to get a cross section of kind of everyday people in Chelsea. We didn't want to necessarily find sick people because sick people are getting testing. So we set up some tables with the help of the town. Tom Ambrosino's group in the city manager's office helped us do that. We had police support as well. We set up a set of tables in Bellingham Square, which is in the middle of Chelsea. And we recruited 200 individuals that were walking by on the street. So we didn't advertise. We didn't want people to be biased to come to us. We just wanted to get a slice of the community that was as unbiased as we could. There's no perfect way to do that, but we tried to do that. So 200 people, you had to be a resident of Chelsea. You had to be over 18 years of age. And you couldn't have had a positive COVID-19 test already. So really looking for relatively healthy people. These were people walking down the street, so none of them were severely ill or moderately ill. Maybe had they could have had mild symptoms. And we tested 200 of them there for the presence of antibodies using what we call a point of care test. It's a rapid test you may have heard about in other stories. It's like a really rapid little test, almost like a pregnancy test. It looks just like a pregnancy test. And if you have antibodies, a band shows up. And if not, one doesn't. So you see those two bands? Yeah. Like that band and that band? Like if you can find those two bands, that one and that one, that means you have antibodies against COVID-19. So it's like really easy. So after doing this random sample, what did you find? Yeah, so we tested 200 individuals, and we found that 31.5% of those individuals had antibodies to COVID-19, and none of them knew that they had it, right? And that's a remarkable number. We also asked about symptoms. And what I can tell you is there was a group of 100 of those individuals reported no symptoms at all, 0 symptoms in the last month. Of those hundreds without any symptoms, about 25% of them were COVID-19 positive or had antibodies against COVID-19. So it's telling us a number of things. There's some good news parts of this story, and there's some not so good news parts of the story. The good news part of the story is that there are a lot of people who've been infected who are doing well, that they're relatively healthy. They've probably come through the infectious process and are mounting antibodies. They're going to do well. They probably will fight off the infection and not get severely ill or hospitalized, and that's a very good sign. It means Chelsea has begun to work through a lot of the infectious process and is further away on its way to what we call herd immunity, which a lot of people talk about, which is in a community, once you have enough people who are immune, the others who aren't immune are protected, right? Because it's hard for that, I use fire a lot. It's hard for that fire to spread through the community if you have people that are immune kind of blocking it from being spread. So those are the good news stories. The bad news story is that we have a lot of people walking around, at least in the high prevalence communities, who are infected or have been infected. And we know that a certain proportion of them, we don't know exactly how many, we're still doing the studies, are infectious. They probably still have the virus. And so that's the problem. People are getting infected, we don't exactly know how. And many of them are still carrying the virus. So that's a real challenge, and we need to do better.
What is this information? How is it helpful to understanding immunity, and what will you do with it?
Mm-hmm. Yeah, we're still at the very early stages of understanding whether this data correlates with being immune to the virus. And what do I mean by immune? Immune means you're not going to get it again. So do we know if you have antibodies that you're not going to get it again? That's what everyone hopes, right? Once I've gone through it and I'm immune, I'm not going to get sick or be hospitalized. We just don't know that yet. And we need that data, and it takes time. There's really nothing science can do here other than wait. We need to wait and see if people have antibodies, can get the disease again. Chelsea is a great community for us to study this. Since they're the most farthest along, we think that could be a perfect community to understand how immunity works for this particular virus. If it behaves like most other infectious diseases, yes, if you have antibodies against the virus, you should be immune. But we don't know that yet, and we don't want to give people advice that you can relax and stop doing social distancing and stop isolating and have people get sick. That would be a disaster, and we would not be doing anyone a service. So we need to be wise in our use of the data, and we're going to work on that. But for now, the data is really useful in understanding the community and what's going on in the community, and continuing to encourage very strongly social isolation, social distancing, I should say, isolation, in certain cases, self-quarantining.
In trying to understand it better, does it mean that you're expanding this type of testing, and how are you doing that?
Yeah, well, one thing I should be very clear on, that this study was anonymous. None of the individuals received their results. And so they were fantastic. They donated their blood. They got finger stick just to help their community, right? They weren't getting the results themselves. I think everyone wanted the results, but we told them we weren't returning them. But now that we know that so many people are positive, we have a duty to go back and I think use these type of tests to identify people who might be infectious and get them isolated. The PCR test, I'll reiterate, is really the best test to find out if you're infectious. But we still don't have enough tests for everybody. So if we can complement PCR testing, especially in people who haven't had any symptoms, right? We could use this test in people without any symptoms. And then those who are positive, we could get a PCR test. We might be able to help with control of the epidemic a little bit, probably a little bit. We can get some people who are currently infectious and get them to isolate. and be more careful. If we can slow things down a little bit in Chelsea, I'll tell you, it'll help Chelsea a lot, and it'll help the hospitals a lot. It'll help MGH a lot, even if we can take a few percentages of patients coming from Chelsea, just slow it down, flatten the curve, so to speak. It'll be a huge help at MGH because we'll have fewer patients, inpatients, fewer ICU beds being taken up. And to be honest, if you're not from Chelsea, maybe you say you don't care, but you should. Because if Chelsea is taken care of, then there are beds available for everyone else who might need it. So it's kind of, we all have to work together on this.
So what does that mean, that you'll ramp up the scale of testing?
We hope to ramp up the scale of testing, but I would say the biggest challenge we have right now is not having enough tests or FDA approval. It's actually knowing what will we tell people. So what do you tell someone? Since we don't know what immunity actually is, what the correlates of immunity currently are, it would not be wise to tell people they're immune and they can relax. I think policymakers, the CDC, the State Department of Health will need to make comments on that and look at the science, but we need more data. So we need to get back out and get more data. We need to start using the test in the community and telling people immediately. The beauty of these tests are within 10 minutes, I can tell you if you have antibodies or not. If you have antibodies, those people need to be sent to one of the drive-through or walk-in clinics for PCR testing. And then we would counsel them appropriately. If you have antibodies and you're PCR negative, you kind of say, look, you still need to be careful, but it's good news for you. It looks like you're probably immune. We can't be sure, but you're probably immune. You still need to practice social distancing, et cetera. If you're antibody positive and you still have virus, you need to be really careful. You need to be, you're already infected, but you have to be careful of your loved ones at home, or if you're going to work, or if you're taking care of especially people who are at risk, older people or pre-existing conditions. So that's what we're thinking. In addition, we're thinking, we're not the only ones. Many people are thinking about doing these type of tests in other communities. So we're trying to evaluate how we can do these type of tests in other communities, and to begin to understand how each community is progressing through COVID-19. One thing I'll tell you is, this is not a state by state or country by country process. This is a neighborhood by neighborhood process, and each one is going to have its own different peak and its own surge, its own peak, and we'll have to discuss neighborhood by neighborhood whether there's herd immunity. And I would tell you, Chelsea has an opportunity to have herd immunity. They have so many infections, but other towns where the prevalence is going to be very low, people have to understand there's no herd immunity there. While the state passed its peak, each town may be in a very different position, and people have to have to understand the true probability of getting this in their community. So we'll learn more, but we need the data. So I think we're very interested in getting out and getting more data, as are other groups, and we're working on that now.
What is the timeline on understanding immunity and getting it right? What does that mean?
That's a great question. I wish I knew the answer to that. I think from a practical standpoint, we would love to be able to tell people they're immune and can go back to work. I think the big question for long-term immunity, I think, is getting the economy back and people working. It's just so important for people. We would like to have some more data. It probably will take a month or 2 or 3 at least to be confident that we aren't getting, especially in a town like Chelsea, a city like Chelsea, that we're not getting reinfections. So collecting the data now, finding out who has antibodies, going back to them in 2 or 3 months. How many of you had symptoms or may have been tested again? If any of you have had COVID-19 a second time. If the answer is none, if we can collect a nice study size and find the answer is none in 3 or maybe 6 months, okay, now we can be confident that at least you have protection for that length of time. I think everyone realizes we're looking just to bridge ourselves to a vaccine, right? We'd like to have people be protected until a vaccine is ready. So we don't need evidence of lifelong immunity here. We would be looking for evidence that you could be protected until we have something available. So, but we're lacking a lot of data, so we need many more people to get out in the field and collect information.
Your insider perspective on how MGH is fulfilling this role when we're at a crossroads of a pandemic, and that happening where some of the world's best healthcare is located.
Yeah, it's great being at a place like MGH, but I would have to say a virus like this is the great equalizer, and none of us really know. So we have very smart minds here. There are many smart minds all over Boston, of course. But really you need data. And so we can predict, many people can predict what we think is going to happen, but we really need data. I would say we have great hospitals here. People are totally dedicated. As you know, people working 24/7 around the clock, just trying to keep things working in the hospital, you know, help patients, save patients. So MGH is a special place, but in many ways, as I said, this is a great equalizer. Everyone in the society has to pull together. Everyone's always talking about these diagnostic tests and how some are really good and some are bad, and you know, PCR is not good, PCR is not bad. You know, you hear everything. And some of these antibody tests are bad, and so it's like really complicated. So what we did is, Joe Lenners in our group, is a physician in our group, put this together for our clinicians in the hospital. And what it shows you is how good the tests are, the detection rate, right? Do you detect 100% of people or 0 based on the days after symptom onset? And so what it tells you is the test, for me to tell you how good a test is, you actually have to know when your symptoms started. Right? And so when people say PCR is not good, the first thing I ask them, well, for who? Right? If you have been sick for a week and you told me PCR was negative, I don't think PCR is any good. Well, yeah, but you don't know what you're talking about, because you should actually be looking only at PCR in the first 3 or 4 days after symptoms start. Because if you're doing a nasal pharyngeal swab, you want a lot of virus in the nose. And so when we talk about good tests, PCR is a great test for symptomatic people in the first 3 or 4 days. It is the gold standard. That is the test. So people who have symptoms need to get tested right away. Like, you just got to get tested right away. But if you waited a week after symptoms, you can see that curve comes down. This is PCR in gold, by the way. So at about a week, only half the people are positive. After 2 weeks, only like 25% of people are positive. So where are you in the process as your body begins to fight it off? Not surprisingly, it comes down. So when understanding how tests work, you have to actually know where you are. And if you don't know where you are, people shouldn't be complaining about tests. Now, antibody test is the opposite. You won't be surprised. The immune system takes a while to kick in, right? The virus is around here during the acute infection period, and the antibodies kick in around day 3 or 4. Maybe a small percentage of people start seeing them. By about 7 or 8 days, about half of people, you'll see antibodies on this little test. And then by 3 weeks, essentially everybody has antibodies. So when you say the antibody tests are horrible, I'll ask you, well, what day did you take the antibody test? And so if you take the antibody test at day 21, essentially everyone would be shown to be positive. And then the last thing to show you is kind of in the middle. If you do antibody testing, a lot of it, what do you notice about people in this range from 1 week to 2 weeks? One thing that you notice about them, it's not a perfect test. Some people's immune system is a little slower. But the other thing that you have to notice is that quite a few of those are still PCR positive. So just because you have antibodies doesn't mean you're immune. In fact, a third to a half, if you pick any of these time points, it's generally like a third to a half of them still have virus and are still infectious.
Wow.
We're hoping that people get out here, right? That they're, we call IgG, antibody positive out here, and they have no virus. That's perfect, right? You have an antibodies and no virus. That's where I want to be.